Recording in progress.
Hello, hello.
Hello.
Good evening.
Good evening.
Good evening.
Good evening, Katile.
Hello, good evening, Katili.
Can you hear me?
Yes, I can hear you.
I can hear you.
Okay, thank you. So I think think we start the sessions and end early. So today we are learning about hypertension in pregnancy, and our speaker today on our session 17 will be Blessing Itoro Ituen, health promotion specialist working with Bliss Foundation, and she'll be taking us through the Blessing. I don't know if you are in.
Yes, I am in.
Thank you, and welcome from Nigeria. So welcome so much, and take us through the session.
Okay, thank you so much, Cecily, for having me. Okay, I'd love to share my screen. So
You can share.
okay, thank you very much.
Za kupika mshapika? Apron mlitoa wapi? Beki za kufunga mlitoa wapi?
Hello, I don't know if everyone can see my screen with me. Hello, Cecily.
Yeah, I can see it.
Okay, because I'm hearing some noises from the background. Hello, everyone with me, please.
Yes.
Okay, so good evening, everyone. Although it's still afternoon here, it's 12 p.m. Yeah. My name is BlessingNse. Itoro Ituen. Yeah, I wanted to get that right. So today I'll be talking to us about hypertension in pregnancy. When Katili told me this was the topic I needed to handle, I felt excited. Excited because I knew it is yet another opportunity to tell people, to communicate with people about some of my experiences, especially with this topic, hypertension in pregnancy. I've had some experiences with mothers, especially, and I've had good ones and bad ones. The bad one I would like to share with us in order to kickstart this lesson or session today is one that happened very close. That was last year. So last year when I was pregnant with my son, I got registered in a hospital. Then I met people, I met friends. One particular woman, we were close because we shared the same date. So one day when we came, the normal day we came for a normal antenatal checkup, something happened. My fellow colleague, a nurse, spoke with her very rudely when she went for a checkup, normal vital check, because your vitals will need to be taken in before you see the doctor. So I noticed the nurse was speaking to her so rudely, and she was not concerned. She was just nonchalant about the whole conversation. After the scenario, I had to meet the nurse and ask her what happened, that it was actually unethical for her to speak to a patient that way. So she drew my attention to her state of health. And I got to realize that this woman was at risk of developing eclampsia. Okay, even after she was told, she did not see it as anything important or something she should do anything about. Even when the nurse actually wanted to help her so she could see the doctor fast and prompt medical treatment started, but she never saw anything. She was just nonchalant. I met her, the woman, I spoke to her, I tried to make her see. Hello, can you hear me? Am I heard? Hi, everyone with me? Hello, Cassidy, are you there? Please, I'll need a response before I go ahead. I just want to know if people are with me.
I'm here.
Okay.
Yes, Blessing, we can hear you.
Okay. Okay, so I was saying I spoke with the woman. I had to make her understand why she should take her pregnancy, especially for her health and the fetus sake. Very important. And I got to realize that she has been having hypertension right from when she was a teenager. So because of that, she wasn't bothered about this pregnancy and the hypertension. So long story cut short, she lost her baby and almost lost her life. How did that happen? In her home during her normal routine, she was going around, then she had a seizure. Okay, with a high blood pressure, she had the first episode. So before they could rush her to the hospital, she had a second episode again. And then it led to her placenta abrupting form. Okay, it led to placental abruption. And because of that, her baby could not get enough oxygen. And because the distance from her house to the hospital was far, so it was too long. But thank God for every nurses and doctors, they could save her life, though she lost the pregnancy. Why am I sharing this particular experience? I'm sharing this experience because many people, most especially mothers, not even mothers, we tend to ignore hypertension. I don't know reason why. Maybe because it doesn't cause any pain, because it's silent, so we feel we can just ignore the whole condition and move ahead with it, but it's not. Hypertension is one of the health challenges commonly encountered in pregnancy. It is common. Okay, it can manifest during or before pregnancy, but whichever the case is, if left untreated, it could lead to a maternal and fetal morbidity and mortality. So anything hypertension requires prompt recognition and treatment. So at the end of this session, we are expected to know what hypertension in pregnancy is, the classification of hypertension in pregnancy, how it's being diagnosed, and of course, the management and treatment of hypertension in pregnancy, and also the preventive measures. So let's run. I don't know if we're all listening. This someone with me?
Yes.
Okay. So what
Yes,
is
Blessing, we are with
hypertension?
you.
Hypertension, thank you very much. Hypertension in pregnancy. What do we mean when we say hypertension in pregnancy? Before I get into the definition, I would like us to know that our normal blood pressure for any mother or any individual is 120 over 80 millimeters mercury, okay, or less. Anything less than 120 over 80 millimeters mercury is considered a normal blood pressure. So if it's above 120 over 80, then to 130, we could suspect first stage of high blood pressure. Okay. Then it gets to 140, that's suspecting the second stage. Though in pregnancy, hypertension in pregnancy is when the systolic and diastolic blood pressure of a pregnant mother is 140 over 90 millimeters mercury and above, okay, on 2 consecutive readings, meaning that you're going to take it twice. The readings are always taken twice. Before you can confirm a pregnant woman hypertensive, you have to take your reading twice and with in an interval. And the normal recommended interval is 4 hours. So when you take the first reading and you suspect the person is hypertensive, you have to wait. Give the person time to rest and go ahead after 4 hours. But I want to make this point very clear because it gets to be confusing. If after a woman's blood pressure is taken, okay, and then severe hypertension is suspected, maybe you've taken the blood pressure or they've taken your blood pressure, and it is suspected that you have, let's say, 160/110. At that point, we don't have to wait for 4 hours to take another reading. We could just tell the woman to rest for 10 minutes. Then we take the second reading. The whole essence is to confirm if the other one was a mistake, the second one won't be a mistake. So it has to be taken twice and with interval. So now if the woman is suspected to have severe hypertension, the period of taking it again can be short. The essence is to facilitate timely treatment, is to facilitate timely antihypertensive treatment, because you cannot see a pregnant woman that is hypertensive and you want to wait, and the hypertension is so severe and you want to wait for 4 hours. Something can happen within that 4 hours you're waiting. So at that point, the interval should be very short in order to facilitate timely treatment. And also, I want us to note this. Since hypertension is measured by the systolic and diastolic blood pressure, and we say from 140 to 90 is declared hypertensive, we should also note that if the upper one, which is the diastolic blood pressure, is normal and the lower number, which is the diastolic blood pressure, is high, the woman is definitely hypertensive, even though the upper number is normal and the lower number is high. Or even if it's opposite, the other one is low and the other one is high. Okay, as far as one there is above normal, so hypertension is suspected and something should be done promptly, especially in pregnant mothers. So hypertension in pregnancy can be classified. Okay, it has classification. It can be classified as chronic hypertension. We also have gestational hypertension, commonly known as pregnancy-induced hypertension. We have the preeclampsia, which my friend had, and we have eclampsia. So classification of hypertension in pregnancy, we have the chronic, we have the gestational, we have preeclampsia, and we have the eclampsia itself. So now, what is chronic hypertension? I still want to bring the case of my friend again. She said she's been having hypertension when she was a teenager. So it means she had a chronic hypertension that resulted to eclampsia. So now, chronic hypertension is a blood pressure of 140 over 90 millimeters mercury and above before pregnancy or before 20 weeks gestation, that is 20 weeks pregnancy. What this means is, if a woman walks to the hospital for the first time to register for an antenatal checkup or care, and she's having hypertension, her blood pressure is high, okay, and she's not up to 20 weeks, at that point she has chronic hypertension. If the woman is not up to 20 weeks of pregnancy and she's having hypertension, it means it is chronic hypertension, okay? And the rate is as high as 22% in every woman of childbearing age. And its prevalence varies according to age, okay? It varies according to age, it varies according to the race, but mostly common among Black women, that's African. And also, of course, the body mass index also contributes to its prevalence. Now, when we're talking about chronic hypertension, many women do well. They do well if they understand their situation. Please, I can hear a noise from the background. Hello, I can hear noise from the background. I don't know why that.
Hello, I have muted them.
Are we? Okay, so are we following, please?
Yeah.
Okay. So now, in chronic hypertension, many women do well if they know their condition, if they take care of themselves and they know the right thing to do. Many women do well. But even though they do well in this chronic hypertension, they are still at risk. They are at risk of either superimposed preeclampsia or fetal growth restriction or placental eruption or preterm birth and cesarean section. Okay, so even if they are doing well, they are still at risk of these conditions I've stated now. And then chronic hypertension, remember I said when a woman walks into the hospital and severe hypertension is suspected, that prompt and medical attention needs to be given to that particular woman. So a question might come, how do you know if a chronic hypertension is mild or severe? How do you know if it's severe? So chronic hypertension is said to be severe if the systolic and diastolic blood pressure is at least 160/110 millimeters mercury. So if she comes and you see that it is at that 160/110, it is severe. At that point, it is said to be severe. Note, you must always take it on 2 readings. And now, how do you know if it's mild? Anything below 160/110 millimeters mercury is mild. Okay. Then causes of chronic hypertension. Causes of chronic hypertension. The causes are divided into categories. So we have the primary causes, which we also call the essential causes, and we have the secondary causes. The primary causes are divided into 2 as well. Under the primary causes, we have the genetics. That is, if it's related to your family or whatsoever, and you're having it, and you're wondering, why am I having chronic hypertension? Why am I having hypertension? You know, it runs in the family. So that's where the genetic comes in. Another cause would be environmental factors. If you're pregnant and your family, there is no one that was hypertensive, and you're wondering, coming from, please. Can you mute? Someone is making a noise in the background. Hello, Kasili.
Next time usiweke zikuwe mingi. Unaona zikuwa mingi kwenye unalalamika. Sawa. Pesa ya Mungu basi.
With the different parties taken into consideration. In some cases, it was very clear that the duty barriers, like the police or the government, for example, or even like the army, they were unwilling to support certain groups, but they had different relationships or different like influence towards the different parties of the conflict. So depending on on the analysis and the scope of your analysis, I think that you can come up with different relationships and influence. But it is interesting to see how different
Hello, Katili.
impact the influence that the stakeholders registers have on rights holders. And again, sometimes it's very difficult to distinguish between rights holders and
Onova, your mic is on and you're speaking.
both categories. Thank you.
Please, who is Eunice? Your mic is on and you're speaking.
And maybe just to be more concrete, when you're talking about in your example,
I can't go on with
and rights holders. Who was that in your concrete scenario?
So we have the scenario of
So please, are we with me? That is settled. Please, if you're with me, can I know? Can you say something?
I am present.
Yes, we are here.
Okay. Okay, please, sorry about that breaking transmission or whatever. So I would love to share my screen again so we can continue from where we stopped before. So as I was saying, I said we're on the primary course, the secondary, the primary courses. So I was saying the environmental factors could be aging. That is environmental factor. If you know that hypertension is not running in your family and you're pregnant and hypertensive, these are the causes. It could be your age, it could be lack of exercise, it could be sodium consumption, too much of it. It could also be the weight, and as well as alcohol consumption and smoking. But the secondary causes could be renal diseases, it could be endocrine diseases like diabetes. So diabetic patients are at risk of having hypertension. It could also be medications, NSAID drugs, example, ibuprofen, Felvin, and so could also cause hypertension, chronic hypertension, and also in pregnancy. So how do we manage or treat chronic hypertension in pregnant women? The management or treatment of chronic hypertension could be, it depends on the severity. First, before you start treatment or maybe managing the hypertension, you check the severity of the hypertension, you check for the presence or absence of any organ damage, and of course, maternal compliance. You cannot go ahead and want to treat or manage hypertension in a pregnant woman if she's not complying. Take my friend as an example. The nurses, the doctors tried helping, but she wasn't complying. And because of that, she lost her baby. So maternal compliance plays a very important role in the management and treatment of chronic hypertension. But in all of this, whatsoever we are doing, maybe trying to manage it or trying to treat it, in all of this, the goal is to ensure the safety of the mother and fetus. So whatsoever we do, we ensure that we are trying to protect them. So now the management and the treatment plan would include use of antihypertensive medication for chronic hypertension. Could be use of antihypertensive medication. The common one that is accepted in pregnancy are methyl-dopa and laetolol. In Nigeria, mostly we use methyl-dopa for the treatment. That is in pregnant women. It is accepted, can be used in pregnancy. Another way of managing it could be lifestyle modification. Okay, you try to limit your weight gain, or if you are overweight, or you have too much weight, we advise you to control your weight. Okay, that's one way to manage it. And of course, limiting sodium consumption, reduce your salt intake. With that, you're also reducing how high your blood pressure gets. And exercising often also helps in the management. Then if the person consumes alcohol or smokes, we try to encourage the person to stop. You have to cease it. You're not like trying to minimize or whatsoever. At that point, you stop. No bargaining. So that is it about chronic hypertension. The other thing we want to talk about, another hypertension classification we want to talk about, is the gestational hypertension in pregnancy. This is another one commonly known as pregnancy-induced hypertension. So if you hear pregnancy-induced hypertension and gestational hypertension, you know that you're referring to one and the same thing. So now, what is gestational hypertension? Remember, we said chronic hypertension is when the blood pressure is high before pregnancy or before 20 weeks pregnancy. So now, gestational hypertension would be blood pressure greater than 140/90 millimeters mercury on 2 occasions from 20 weeks of pregnancy. Okay, any hypertension that is starting in a pregnant woman after her 20th week of pregnancy means that she's having gestational hypertension. That means it is pregnancy induced. Okay, it is because of the pregnancy. Okay, I don't know if we're all following, but I believe we have. Now, gestational hypertension is defined by blood pressure greater than 140/90 on 2 occasions from 20 weeks of pregnancy without the presence of proteinuria or other clinical features suggesting preeclampsia. So if she's pregnant and more than 20 weeks, or from her 20 weeks, and she's having high blood pressure, without proteinuria. What is proteinuria? Proteinuria is the presence of protein in urine. Okay, because I know it's done in Kenya. When a woman comes for hello, Katili. Please, are we with me? Are you guys with me?
Yes, we are.
Okay, thank you. So I was saying proteinuria is the presence of protein in urine. Here in Nigeria, I know it's done everywhere. When a woman goes to the hospital for her antenatal registration or whatever checkup, as far as she comes, her urine is always tested for protein. So now, if a woman that is above 20 weeks pregnant comes and is hypertensive without any protein in her urine or other clinical features like headache, edema, impaired kidney functions, or low-level blood platelets, it means she has just pregnancy-induced hypertension and also could be managed well. Now, who is at risk of, although we are talking about pregnant women here, okay, but in this pregnant women, this group of people, who is at risk of this gestational hypertension? Women at risk are first-time mothers. You know, as a first-time mother, I myself, I had gestational hypertension. So first-time mothers, women with genetic history of hypertension, if it runs in the family, know that you are at risk. And women carrying multiple babies also are at risk of gestational hypertension. Women younger than 20 years or older than 35 years are also at risk. Then women with history of hypertension or kidney disease, okay, if they have history of this, they are at risk of having hypertension in this pregnancy. And of course, Black women, okay, we are at high risk of developing gestational hypertension. So then the next thing we want to talk about is the classification of gestational hypertension. Gestational hypertension can be classified as mild gestational hypertension. It could also be classified as severe. Okay, I want us to know that whatsoever that concerns hypertension could either be severe or mild. So if a woman is, how do you know if she has mild or severe gestational hypertension? If the gestational hypertension starts after 30 weeks of pregnancy, if it starts after 30 weeks, then it is said to be mild. Okay, it's mild because she's almost late. It's not that serious. Not to be taking no, it's mild. Can just give, you can, as long as she doesn't have proteinuria, you could just give antihypertensive drugs and she goes on bed rest and all. It's mild. But if it starts before 30 weeks, maybe the gestational hypertension starts from at 20 weeks of pregnancy or before 30 weeks, or anything before 30 weeks means it is severe, okay? And that woman should be handled with care. Because at this point, I can still hear noise. Okay, so I'm saying if the gestational hypertension starts before 30 weeks of pregnancy, that is, maybe it starts from 20 weeks, know that that woman should be handled with care because that is severe gestational hypertension. And the possibility of it advancing to preeclampsia is 50%. So you need to care, or if the woman is you yourself, you have to take very good care of yourself and be careful because you are at risk of having preeclampsia as far as your hypertension started from 20 weeks or before 30 weeks. So that kind of woman is at risk of developing preeclampsia. Now, management of gestational hypertension, how is it managed? Like I said in the chronic hypertension will need to be managed depending on the severity. Okay, so for gestational hypertension, it will depend on the severity and how high the blood pressure is. Okay, now if a woman with blood pressure above 140/90 millimeters mercury comes to the hospital, that kind of woman, that is above 140, that kind of woman will be immediately admitted. I do advise people to admit such woman above 140 should be admitted in the hospital and not let to go back. Or if less, then she will be asked, let's say if it's 135, she will be asked to stay at home. And at home, she will be on bed rest. Okay, so know that one way to manage it is any woman that presents herself in the hospital and she's above 140, automatically you are being admitted, you're being hospitalized. But if it's below, then she can be advised to be on bed rest at home. Then administration of antihypertensive medication will be given. Then we conduct proteinuria tests. That is another way, so that you know what you are facing, so that you know if indeed it is gestational hypertension alone or not preeclampsia. Then full blood count and organ test also is conducted. Then regular assessment of the fetus. This one cannot be overrated or overemphasized. Our fetus need to be assessed regularly through the ultrasound. Then for women with blood pressure 160 above 140, that's 160/10 and above, we will have to plan early birth. Okay, if our blood pressure is above 140 and then she's not up to 37 weeks, we plan early birth, because if you want to delay for the fetus to be developed, you could be putting the mother and the fetus at risk. So we plan for early birth before 37 weeks for women with blood pressure 160/110 and above. And also, if she has other medical conditions, let's say she's diabetic, you know that you're planning to deliver that baby before the baby gets to full term. And also another way to manage is lifestyle modification. We've talked about lifestyle modification. That is reduction of sodium consumption, regular exercise and all, which was mentioned earlier. Then after birth, how do you manage after birth? A woman with gestational hypertension. After birth, for women who were treated with antihypertensive drugs, most especially methyl dopa, okay, the treatment will need to be stopped within 2 days. An alternative treatment will be given. But if methyl dopa was the drug that was administered, she will need to stop that and another treatment given. Then if the woman that had gestational hypertension, if the blood pressure falls back after birth, then you just let the woman breathe, or you reduce the dosage, or you reduce the treatment. Now, for women who did not take any antihypertensive treatment and drug, let's say the woman that had mild gestational hypertension, for that woman, and after birth, her blood pressure rises, okay? At that point, if after delivery, maybe 1 day or 2 days, she starts developing high blood pressure, for that kind of woman, antihypertensive treatment will need to start immediately, okay? So that it doesn't get to eclampsia, because eclampsia can also occur after childbirth. So if a woman that just finished putting to bed develop high blood pressure, at that point, antihypertensive drugs will need to be given immediately. I don't know if we are following. Are we there, please? Are we following? Please, are we following before I move to the next slide?
Yes, we are.
Okay, thank you very much. So another thing we want to talk about is preeclampsia. I've mentioned it when I was telling us the story about my friend, and now we are talking about it. Preeclampsia. I said gestational hypertension is the hypertension that starts after 20 weeks of pregnancy. Now, preeclampsia, okay, the other one is without protein in the urine, proteinuria. Now, preeclampsia is the high blood pressure. Now, when we're talking about high blood pressure, yeah, we are talking about something from 140 to 90, 140/90 millimeters mercury. So I might not really mention the numbers now. So I'll just be referring to high blood pressure. I don't know if that's okay. So now preeclampsia is when a woman's blood pressure rises above 140/90 millimeters mercury, okay, with the presence of proteinuria. Note, gestational hypertension doesn't have proteinuria, but preeclampsia has proteinuria. So if a woman presents herself to the hospital and she has high blood pressure, and then her urine is tested and there is protein in her urine, that means she has preeclampsia. And that woman should be handled with absolute care. I mean care. And if the woman is among us, someone is making a noise in the background. Okay. So any woman with preeclampsia should be handled with care. At this point, she's delicate to every health practitioner because her condition is a very risky one that could harm our baby and herself. So preeclampsia is a condition that is so risky. Now, it usually starts after 20 weeks of pregnancy in women whose blood pressure was normal before pregnancy. So it starts after 20 weeks of pregnancy. Now, this preeclampsia, although it is diagnosed by a woman having protein in her urine, there are other ways that it can be diagnosed that cannot be diagnosed. Like, for instance, she comes and she does not have protein in her urine, but she has the following thing. She has a high blood pressure of 140/90 and above. She has headache. She has thrombocytopenia, that is low levels blood and palette of blood. She has shortness of breath. She has impaired liver function or changes in vision, any visual disturbance. If she has all these things I've mentioned, but she doesn't have proteinuria, it means she has a preeclampsia. So aside the woman having proteinuria, these are other symptoms that follows. Okay, so a high blood pressure, headache, thrombocytopenia, shortness of breath, impaired liver function, then visual disturbance. It could be loss of sight, it could be blood vision, it could be sensitivity to light, but any of these that presents with high blood pressure is classified preeclampsia. But then there are other things, other symptoms of preeclampsia that I want to talk about, although it is not reliable, very reliable. It is not like a yardstick. Why I'm saying it's not like a yardstick is because it occurs in other normal pregnancies. And those symptoms are sudden weight gains and swelling. It is common in normal pregnancy. So I wouldn't want to include this to the main symptoms of preeclampsia. Another thing is nausea and vomiting. It is very often. But then if a woman comes and presents these symptoms, you should also start suspecting preeclampsia. Causes of preeclampsia. Till now, the exact cause of preeclampsia is not known. Researches have been going on. Then there are thoughts, people have given their thoughts to be why a woman has preeclampsia, but the exact cause is not known. But then, presently, preeclampsia is thought to be as a result of improper functioning of the placenta. Improper functioning of the placenta, including insufficient blood flow to the placenta. Many people would say because of preeclampsia is because of insufficient blood flow to the placenta. It's just a thought, but it is not proven. Okay. Then other factors that could cause it could be excess body weight. It could also be poor nutrition, and of course, genetics. Okay, if a woman is having it and it runs in the family, someone in the family had it before and she's having it, we might say is the factor contributing to her having this one here. Now, risk factors associated with preeclampsia. Family history. If a woman had has chronic hypertension, it means she's at risk of developing preeclampsia. And of course, the age. If the woman is younger than 20 or older than 35, that means she's at risk of developing preeclampsia. Then Black women, African women, we are also at risk of developing preeclampsia. Then the interval between pregnancies. If a woman was pregnant 1 year ago and the next year she's going again, she's at risk of developing preeclampsia. And if a woman waits for more than 10 years or longer as 10 years, when she gets pregnant again, she's at risk of developing preeclampsia. Another factor is multiple babies. Women carrying multiple babies. Any woman carrying more than one baby is at risk of developing preeclampsia. Now, how is preeclampsia managed? Women with preeclampsia, how are they managed? The only cure for preeclampsia is delivering the baby. Okay? That is the only way there is no drugs that you can give a woman to treat a preeclampsia. The only thing that can be done in order to cure her of that condition is delivering the fetus. Other than that, it can only be managed till when the baby is being delivered. But however, I want us to note that any woman with preeclampsia, the symptoms may persist even after delivering the baby, but will stop in at least 6 weeks or 12 weeks postpartum. So if a woman presents herself in the hospital and she says she's still experiencing the symptoms of preeclampsia, there's still protein in her urine, and she has put to bed, you will have to tell her to wait. After 6 weeks, it will clear off. 6 to 12 weeks, it will clear off and she will go back to normal. So management of preeclampsia will depend on the severity. Since the only cure is delivering the baby, how do you manage? For mild preeclampsia, that is not in pregnancy, that is not up to 37 weeks. If the preeclampsia is mild, the baby and the mother can possibly wait and deliver the baby when the baby is at full term. Okay, maybe when the baby is up to 37 weeks, you could wait till that time for women with mild preeclampsia. But then she will be closely monitored. She'll have to be monitored very closely, either from home or hospital. But if she's being monitored from home, that is for women with mild preeclampsia. If she's being monitored from home, she will need to be on bed rest, constant bed rest, to try to lower the blood pressure and also to increase the flow of blood to the placenta. And she will be on antihypertensive medication. Just like I said before, the common ones use is Lapsolol and Metulzol. I think that's the only acceptable one. Then we'll continue to monitor our blood pressure to see in case it rises. Then regular urine and blood tests to know if the preeclampsia is progressing. Then regular monitoring of the fetus. This is another thing that will also determine how well she's managed and how long she will be managed. When you assess the fetus for the growth, the heart rate, and the amniotic fluid, and you see that it's abnormal, at that point, we deliver the baby, even if it's not up to 37 weeks. Okay, but if everything is normal, we wait till 37 weeks. That is for mild preeclampsia. And of course, very important, anticonvulsive drugs will need to be given to any woman with preeclampsia. The common one that is given is magnesium sulfate. It has to be administered to the woman to prevent convulsion, to prevent seizures. So it has to be given as a form of management. Now, in severe cases of preeclampsia, these things I've been talking about, the mild ones, but in severe cases of preeclampsia, the woman will compulsorily be admitted to the hospital for
115.
and then if the pregnancy is up to 34 weeks, delivery will take place as soon as possible. For women with severe preeclampsia and her pregnancy is up to 34 weeks, she will need to be delivered as soon as possible. But if the pregnancy is not up to 34 weeks, then at this point, steroid will be administered. Now, why are we giving steroid? The essence of giving the steroid is to help speed up the development of the fetal lung, okay? It's also to help speed up the maturity of the baby so that she can be delivered. I don't know if we are following. Are we following, please? Please, are we following?
Yes.
Okay. So, as I was saying, if the pregnancy is less than 34 weeks, steroid will be given. When steroids are given, we wait for 48 to 72 hours before delivering the baby. Now, the essence of waiting is to give the drug time to start working and the lungs to start developing before we deliver any baby less than 34 weeks. Also, of course, antihypertensive drugs and anticonvulsive drugs will be given to the woman in order to control blood pressure and also to prevent seizures. Now, I know I'll be expecting this question. How do you know if preeclampsia is mild or severe? Please, I can hear a voice from the background. How do you know if preeclampsia is mild or severe? Preeclampsia is said to be mild if the blood pressure is 140/90 or below, okay, with the presence of protein in urine that is not up to 2 plus. So if the protein is tested and it's not up to 2, the plus is not up to 2, okay, we can say she's having mild preeclampsia and we can monitor her and wait till when her baby is up to 10. Then preeclampsia is said to be severe if the woman's blood pressure is 140/90 and above with a proteinuria test that has up to 3 plus. Okay, if a protein is tested and it's up to 3 plus or more, that means the preeclampsia is severe. And then if these other symptoms follows, maybe she has headache, she has any visual disturbance, temporary loss of sight, blood vision and all, then she has thrombocytopenia or edema, then you know this is severe and immediately the baby needs to be delivered. Please, are we all following?
Yes, we are following.
Yes.
Okay. So now the next thing we want to talk about is eclampsia. Eclampsia itself is a very risky and emergency medical condition that I myself am always scared of. I've had one experience where a woman convulsed in my presence. I got scared. That was my first time. I was still in school. I didn't even know she had a preeclampsia, but this is a condition that should be taken and handled very carefully because it could lead to instant death of a woman and a baby. So, what is eclampsia? Eclampsia is defined as the onset of convulsion or seizure in a woman with preeclampsia.
So that's kind of thing. So you
can hear a noise from the background.
you are the KU, they are looking up to you, they say, this is the dress this way.
Okay. Eclampsia is defined as the onset of convulsion or seizures in a woman with preeclampsia. So any woman that has preeclampsia and she's convulsing or having seizure, like the seizure that you see when an epileptic person has, know that this woman for sure is eclamptic. And that this was the case of my friend. She had eclampsia and she almost died. Thank God for good medical doctors and nurses. So it is usually considered a medical emergency and immediate treatment. I mean, prompt treatment will need to start in order to stop the seizure, lower the blood pressure, and deliver the fetus. So eclampsia is an emergency, a medical emergency that needs immediate attention. Okay, and World Health recommends prompt delivery of the baby, even if the baby is still very tender, irrespective of the gestational age. You are not to wait. Even if the woman comes and she has a eclampsia and she's just 20 weeks gone, you have to deliver the baby. That is what World Health recommends. Okay, eclampsia may lead to coma, okay, that lasts within minutes or hours. Might last for a few minutes, could be 2 minutes, could be 5 minutes, sometimes it could be hours, where the woman will just enter coma. But then it depends on the frequency of the seizures that the woman had. In my friend's case, she almost fell into coma because she had her second episode in the hospital. That is what saved her. The second episode she had, immediately they gave her magnesium sulfate and it stopped the seizure. That is what saved her because she was in the hospital. But mostly the coma happens and if prompt medical attention is not given, might last for hours. So how is eclampsia managed? Because we all know that it cannot be treated except delivery of the baby. That's the only thing that cures it. So when a woman has eclampsia that is convulsed with pregnancy, the first thing you do is to try and stop the seizure. That's the first thing that ever happens. Try and stop the seizure, and mostly using magnesium sulfate. It will be given as intravenous, through intravenous means or injection, but the whole essence is to try and stop it. So another thing that is done is to control the blood pressure. So antihypertensive drugs will be given in order to control the blood pressure. Then when the woman is stabilized, after you've given the woman magnesium sulfate and you've given the woman methyl dopa to stop the seizure and to also control the blood pressure, and the woman is now stabilized, that is when she goes for CS. Because at this point, she is not, you can't advise or even talk about her trying to go for vaginal delivery. At this point, the only thing is cesarean section. Okay, so when she's stable, we deliver the baby through CS, and then we'll continue anticonvulsive treatment for 24 hours. If she, after delivery or after convulsion, if she convulses last, that means what I'm trying to say is if after she delivered her baby, she started convulsing, okay, now you continue the anticonvulsive treatment for 24 hours. But if she convulses and before delivery, after delivery, you still continue the anticonvulsive treatment for 24 hours. So whatever comes first and comes last, continue the anticonvulsive treatment for at least 24 hours. Then you continue antihypertensive treatment till when the woman's blood pressure returns to normal. And of course, before you discharge the woman, she has to be fully recovered. So you monitor the woman carefully until she's fully recovered. That's when she will be discharged. Please, are we all following? Are we
Yes, you're
following, please?
Yes.
Okay, thank you.
Yes, we are.
Prevention of hypertension in pregnancy. Hypertension in pregnancy, although can be managed, can be controlled, but then it cannot be prevented, especially for women that 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 has family history, risk factor, past pregnancy, or pregnancy with multiple babies. Any woman that falls into this category cannot prevent hypertension in her pregnancy. But then it can be controlled. Okay, it can be controlled. Then lifestyle modifications such as regular exercise, eating healthily can go a long way for women that are just maybe first timers and are carrying one baby. Okay, those ones lifestyle modification can help to prevent it. But for women that are carrying multiple babies or they've been pregnant before, you cannot prevent it. The only thing you can do is to try your best to lower the risk. I don't know if you understand. You cannot prevent, just try to lower the risk by eating healthily and of course balanced diet. Then limiting salt intake and also exercising regularly, avoidance or cessation. Avoid it if you've not been taking it, and also cease if you've been consuming alcohol or smoking. So this will also help to lower the risk. And of course, regular antenatal checkups goes a long way in helping with the prevention of hypertension in pregnancy. So do we all understand? Hello, are we there?
Yes.
I've spoken and taken time. So that is all about hypertension in pregnancy. For a recap, it can be classified into four. We have the chronic hypertension, we have the gestational hypertension, we have the preeclampsia and the eclampsia. And of course, I've taken us through the management and how it can be managed and the treatment. And I believe we all understand what to do at any circumstance. Then I would love to know, because I'm ending here, I'm going to stop here. If we have any questions, this is when I want to answer them, please.
I have a question.
Okay.
So on the management of the eclampsia,
Okay.
I can see it is the medical management of it. Do we have like a first aid for it before this mom is transferred to the hospital, like a first aid at a home setup, something of the kind? For both
like a first aid you can administer to the woman before she gets to the hospital.
Yes.
Is that what you mean?
Yeah.
A first aid. Basically, what if a woman is convulsing, a pregnant woman is convulsing, the best you could do is the first aid given for epilepsy is to clear the environment. Clear the environment, prevent her from hitting the womb until when the seizure is calm, you take her to the hospital. There is nothing you can do. The best thing you do is to make sure she gets to the hospital fast. Because at that point, the only thing that can be done is to deliver the baby. I don't know
Okay.
if you understand.
Yes, I've understood.
Thank you. Please, do I have another question? Any other question, please? Katili. Katili.
Yes. Maybe from the participants, I can see a question in the chat box. Can preeclampsia recur in another pregnancy, like firstborn, you had it, then secondborn, it occurs again?
Definitely, it can. It
Thank
can,
you.
as far as you've experienced it before. So in your second pregnancy, you are at risk of having it again.
Currently, if you're participants, you can always mute when you're not speaking. So I don't know, is there any questions from the participants? Because I can't see any other question in the chat box. Anyone who has a question? If you understood, you can use the thumbs up in the chat box. If you feel this, it was well tackled and you understood everything, you can just use a thumbs up. I can see Joyce, Leonida, Lynette, Gikuru, Irene. I can see a question. Irene is asking the clarification of what is systolic and diastolic. Those, I guess, they are heartbeats.
Okay, what's the person wanting to know?
I
Do you
asked,
want to know?
the clarification, she's asking what is the difference between systolic and diastolic.
Oh,
I
I thought
yeah.
Okay. For the systolic and diastolic blood pressure is like, let me say, the systolic is the measurement of the number of times your heart beats. Okay, that is for the systolic. It's measuring how the number of times your heart beats. Now the diastolic is measuring the time it rests at interval. You know, when it beats, it rests. Boom, boom. So the diastolic is the time it rested, and the systolic is when it beats. That's the simplest way I can put it. I don't know if the person understands.
Hello. Can you
Yes.
hear me? Okay, I get you. This is Irene. Thank you so very much for answering my question.
It's
And
okay.
thank you so very
You're
much
welcome.
for informing us about this.
It's my pleasure.
We have a question from Esther. Esther is asking, if a woman who has an history of eclampsia is there, if a woman has a history of eclampsia, is there a given period of time that one should wait to conceive again?
Yeah, you have to wait for 2 years. 2 years or more.
Eunice, I think you answered, or you need clarification. Do you have another question? Eunice is saying thank you. Jacqueline, thank you. Emily, thank you. Those who are following us from FB, I can see a question there.
Okay, I think I can see a question while we wait for you. Katini?
Yes, there's someone asking why you should wait for those 2 years.
Okay, I wanted to be sure. So normally, even without the woman having eclampsia, you're supposed to wait 2 years to allow your body to heal and to return back and to be ready to take in another baby again.
Thank you for that. Jace is saying thanks a lot for this session. I can see Maslin following. So maybe before we end the session, we can have someone from the group to give feedback about the session. Jackma, you can give like a recap about the session. Someone from the group to say how the session was.
Hello, good afternoon, good evening, everyone.
Good evening.
I didn't want to talk. I wanted also to nominate somebody to speak, but thank you so much. Thank you so much, Blessings, for creating time and discussing with us today. We are again humbled. And as well, we are happy to have you on board, the participants. We can't have these discussions without you, those who are joining us on Facebook, and as well those who are joining us via Zoom. So we thank you for your time, and we thank you for creating time always to discuss with us, to be in these discussions. And I hope you are learning something new day in, day out. And today already now you have garnered knowledge and skills on eclampsia. And I hope we'll really take those keynote discussions into a level community-based discussions that we can always talk about at various capacities. Thank you. I have nothing to say, but only to say we appreciate your time and your indulgences as well. Back to you, Katile. I'm sorry, niko kwa barabara.
Thank you so much. Thank you so much, Joshua, for
so much. Thank you.
I really appreciate that. Maybe I can read from the chat box. Gikuri saying it was a very informative session, informative session. Jacqueline Oma, very informative. Thanks for the good presentation to our speaker. Nutritionist Shayla is saying awesome session. Thank you to our speaker. Banuna is saying the session for me was great, though multitasking, it was very informative. So I think from the participants, it was an awesome session. So maybe I can go back to you, our speaker, to give your parting shots.
Thank you very, very much, Katili, and everyone that participated today. I'm really excited to get this feedback, and it's motivating to do more. And I believe that after we've learned these few things, that we will be able to educate other people, our sisters, mothers, friends. We could use this knowledge to educate them to take the right step towards their health and in pregnancy. Thank you so much for having me. Thank you so much for your attention. God bless. I really appreciate it. Actually, thank you for having me.
I really appreciate and I'm so happy for your time. Lastly, we have from Beryl, thank you so much. She has done a lot. So with that, we can end our session there. Have a good evening, everyone.
Same to you.
Good evening and bye, everyone.
Bye.
Bye.
Bye.